Hello, dear listeners, dear viewers. I'm very honored that this is the first Hürzeler interview today with Professor Markus Hürzeler, which I am going to have an interview on a very interesting topic. So this is a new format that the Hürzeler Academy is trying to set up, and an international advisor will interview Dr. Zuro, Professor Markus Hürzeler, during one of the sessions on various topics in the coming weeks, months, and hopefully years, Markus. Maybe we will see. Okay, we will see. I have something special. Well, it's not really something special. I could choose the first topic today. So I chose soft tissue augmentation around implants in the aesthetic zone. We don't have like 2 days to talk on this topic. So I had a lot of questions coming from social media, from people that wants to know about this topic, and had some very interesting questions going very into detail. And I've tried to bundle them a little bit so that we can have a nice informal chat about this topic. I'm just going to shoot the first one. The first one is, what do you, if, for example, there was one colleague that asked me, if, for example, you need a very big graft from the palate, for example, 3 centimeters long, would you prefer to take it in one piece on one side, or would you prefer to go bilaterally or take it wider and then split it? Or how would you approach these things? Because we know that there might be some quality issues between anterior and posterior. How would you approach this?
Yeah, this is a great question. It's actually at the moment very, very difficult to answer this question because, as you already mentioned, Andy, it seems to be that there are huge differences, not only apicoronally on the palatal side, as Otto myself thought. It seems to be also a huge difference in the immunohistochemic analysis between the anterior and posterior area of the composition of the tissue. And we might get completely different reactions in the site where we are going to place these grafts. So knowing all this, or let's say starting having more knowledge, more and more, it seems to be critical to harvest in one piece, such a big piece as your participant asked you. So I think it's at the moment a situation we start to know more, but knowing that, I would even think more in the direction using on both sides in such a situation. It becomes very critical, you know. I'll give you an example. When you harvest the graft on the palatal side and you do, for instance, the published single incision technique from us, and you don't do it right, that means you make your cut in the palatinum not like this. You don't create a real flap on the palatal side, which is about 1.5 millimeter thick, and then you split down here, and then you really take the tissue underneath. You do your first cut like Harris showed it. You cut like this in the palatinum. You go here in the palatinum like this. And then you have here at the top, in this region, a lot of very superficial lamina propria. And this is already different. This tissue already reacts different than the more deeper one, which you take more apically then. And so this question is really amazing good, because already that can have a huge influence in the site where you're going to place the graft. And this is really detailed now. And this is what sometimes we have the experience. We don't have yet really solid data to support that, but this is what we are working on at the moment.
Yeah, so we can actually conclude that a graft is not a graft. So there are very different types of graft depending on which technique you are using to harvest it, but also the region in the mouth or the palate where you're going to harvest it makes a hell of a difference when you are going to the surgical field afterwards, and which you want to achieve, the outcome you want to achieve.
That's an incredibly important point you made, Andy. This is something Otto myself always emphasize on the stage, that during lectures today you always hear, and then I took an autologous connective tissue graft. And the major question here is really, where do you harvest this autologous connective tissue graft? If you don't add this, and this will be in the future absolutely mandatory, that the speakers, the lecturers have to say which one they took, how they took it. This is crucial. This has a huge, huge impact on the outcome, for sure.
Yeah, definitely. So you see, this was just the first question, and indeed we're already diving into big details on this behalf. Just to go further on this notice, there was one question actually from a colleague here in Belgium that asked about if you want to increase keratinized tissue. This maybe can also be related to posterior side. If you want to increase keratinized tissues, can you influence this at the free gingival graft itself? And we are meaning the color characteristics. Do you have any idea how maybe you can influence this?
Yeah, this is a lot of discussion about that. I had this discussion already when I started learning free gingival grafts around teeth in 1984, 85. I started doing that, and my teacher at that time was Professor Temmerman, who everybody knows about the CEREC system. And not many knows that he is actually periodontist. His PhD was about perio topic. But he taught me that, and he said, yeah, by making it a little bit thinner, you may have an influence on the color, but it is not predictable. So the only way you can have maybe an influence, and this also we did already at that time, was called the papilla graft. And the papilla graft is an option when you have to do some increasing of the keratinized tissue in the anterior area, and the aesthetic outcome is very, very important. Then you might have a chance to harvest the graft on the outside. So sometimes in the in the molar area, on the first and second molar, you have a wide band of keratinized tissue, and then harvest this graft. This fits in the color most of the time much better than when you go to the palatal side. This is an option we would go when aesthetic is absolutely crucial. But on the palatal side, by changing the thickness, tried that, but this is not predictable. There's no about that. This will not work. I'm convinced about that. You know, Merman created the mucotome to harvest the free gingival graft with a machine. This was a machine, the mucotome. You could harvest in different thickness. You had different knives created, 1.2, 0.8, and 0.6. And then we tried this already at that time, because he also thought when it's thinner, you might have a positive impact on the color, but it didn't work. This is different patient to patient.
Now, of course, if you say maybe you can harvest on the vestibular side, but I've been looking in my patients for like in every patient where it might be of an aesthetical importance on the vestibular side, and I maybe had like 2 or 3 patients in my career, which is now 15 years long, that were able where I was able to do so. So they don't run like 10, 12 in a dozen. They are very scarce.
Yeah, absolutely. This is normal what you just got. We also get it like this. And this is the only thing we try is using, we call it at that time the papilla graft, because we took very small grafts out of the papilla area.
Yeah.
But sometimes we do it today when we have a wide band, we take it from outside. That's the only thing I would recommend. But also there, honestly, it might help, but it's not so predictable 100%. Yeah. I agree completely with you about this topic.
Now we are just 2 questions far, and we have already discussed quite a lot of things just on grafting, just on the graft itself, how we can maybe influence the quality, how we can influence the color. And actually, you have already answered another question that I got. We can be very short on this, because I probably, if you are starting on this one, we will be here during midnight. So we're going to be very, very short on this one. What is your view? And actually, I got this question 2 times already from 2 colleagues, one colleague of Croatia and another one from Switzerland, who asked, what is your view on soft tissue substitutes nowadays? For example, acellular dermal matrices, etc. What is your view on that? And I think you already mentioned it.
This is really a question, as you said, we can discuss long time together. But generally, I would say our opinion is a little bit controversial to many opinions. We don't think at the moment that we have really a substitute for the autologous connective tissue graft. And, sometimes you get the feeling we understand the so-called gold standard, the autologous connective tissue graft. But looking more and more inside this topic, we found out more and more that we don't understand the gold standard at all. And now we are already discussing substitutes of the gold standard. And looking at, as you said, we have 2 major issues we have to discuss with soft tissue augmentation. It's not only the volume we create, the quantity, it's also very important, the quality, to address the quality which you create. So quantity is one issue, and quality is the other issue of the tissue afterwards, specifically the aesthetic zone. How does it look like? And when we look at the quantity, it becomes more and more obviously that the substitutes you will run in much more resorption. They don't give you the volumetric stability of what you augmented. This becomes more and more obviously. On the other side, when you look at those data, the substitute have a lesser influence on the quality of the tissue. So they resorb faster logically, but on the other, and then they don't change the color, or you don't get, the so-called white patches you get when sometimes you place a lamina propria underneath the mucosal flap. This comes through the mucosa, and then you have really not nice looking white patches. You can create cysts coming out after 5-6 years. Invagination comes out, specific in not very nice areas. You do a covering of recession on the canine, and then after 5 years, you get there an invagination. Doesn't look nice either. And sometimes another real problem, in our opinion, is the growing of those tissues. So there, actually, I have to admit that the substitutes are a little bit better because they don't change, or you don't see this kind of reaction in the tissue when you use them, but they don't maintain the volume so well. So it's a very interesting topic. And as I said already, we think we should know a little bit more about the gold standard first. Before then, we have the companies creating for us substitutes, which then really fulfill the different requirements we actually have, It's a really hot topic. I think it's not yet, or it's impossible to give all the answers at the moment.
Yeah, definitely. Yeah. If you just, just not going into the discussion, but just give me a number of years, for example. Now, if we are now 2025, we try to enhance our knowledge on the graft, and then they go to soft tissue substitutes. How many years do you think we still need? Like 5, 10, 15?
You know, at the moment we are in a situation which we think we need to change a lot in our field to become better in this direction. What we address here today in this interview is aesthetics. And you know, at the moment we evaluate our success around implants with pink aesthetic score and around teeth with the Cairo aesthetic score. These are the two most used evaluation parameters we use. And they were both published in 2005 was the pink aesthetic score, and 2009 was the Cairo aesthetic score about covering a recession. And in our opinion, we need to change those parameters first. And then it makes sense to go further in detail with everything what we discuss here. You know, it's more than 20 years ago now, or it's 20 years ago that they were created. And at that time, it was a revolution, and it was really good. And it was, in my opinion, the best what could happen for plastic aesthetic dentistry. But 20 years later, we know a lot more. And, you know, I could show you cases where, according to the literature, according to pink aesthetic score, it's a success. But according to the patient, it will not be a success. A very simple example is these white patches. You know, you can have, for instance, all the parameters perfect, what the pink aesthetic score addresses, but you have a white patch on this implant, which is for the patient absolutely crucial. If this white patch is there, it's not a success for the patient. But according to the literature, the pink aesthetic score is about 11.5, so it's a success. And this is a huge problem. So we need to change the priority of the different parameters. That's our opinion, what I just said. The quality is addressed in the pink aesthetic score, but only with 2 points. And, you know, this is a huge problem then. When we put at the top, priority is quality of the tissue we create at the end on our defect, then things will look different. And once we have improved that, then we can start to evaluate our target connective tissue graft better. The different one, what impact it will have on the quality, and then also on the quantity. So these are the two things we need to do. We need to look more at the quality and to look more at the quantity. This is what we try today more and more to analyze the volume. But the quality is, well, this is a huge problem. So I would assume, as you ask me how long it lasts, takes a long, if you want to change that first, and then another 10 years for sure, 15 years, 10, 15 years for sure.
Yeah. So there is still a lot of work to do in those consensus meetings.
Yeah, a lot of work, and specifically for the young, you know, researcher, it's amazing. It's, my opinion at the moment, the young generation, our field is so great. It's amazing how it's progressed. And, you know, as we all know, the more you know, the more questions come.
Definitely, yeah. But it's also very difficult to change things. For example, if you look at literature nowadays, still the success criteria by Albrechtson are still referred. Nowadays, if we, for example, would use these criteria on implants, we cannot say that this is longer a success for our patients if we use these criteria, and still they are being used in papers. So,
Yeah.
so it's very difficult to change these things.
Absolutely. I completely agree. Human beings like to be always in the comfort zone.
Yeah, that's true.
That's
That's
why
true.
everybody prefer to be in the comfort zone instead of, let's go ahead. Let's
Yeah,
improve. Let's improve. This is what we
yeah,
need to do.
indeed. So we discussed already on the graft itself, and then a little bit on these kind of substitutes. What you think about this? And now let's go more into the aesthetic region, and talk about soft tissue augmentation and around implants in the aesthetic zone. There was one colleague who sent me, this was via Instagram, I presume. For example, if you have placed, or another colleague has placed an implant which has been loaded for, let us say, 10 years, and there is now a vestibular dip in the tissue, and at all of a sudden the patient is complaining about this. For the rest, the implant is in good health. There's nothing wrong with the implant. What would be your technique of choice in this situation? We are talking about just a vestibular dip, for example, on a 1-1 or a 2-1, which on an implant that has been loaded already.
Today it's pretty clear that we would always try to maintain the implant, the aesthetic zone. If you take it out and start from the scratch, it's for the patient a nightmare. We have to be honest. And as you said, now you say implant is very well integrated, no bleeding, no deep probing depth, and so it's clear the bone is there. Then we would rather go with a plastic reconstructive surgery. And it's pretty clear, that when you have to deal with peri-implantal defect, they are always three-dimensional. Most of the time, not like a natural tooth. And natural tooth with a recession is most of the time a more or less two-dimensional problem. But in an implant, most of the time, it is not only covering vertically this defect, but also a lot of horizontal is necessary. And having said that, it becomes obviously that we think that we need to create special surgical approaches for this kind of defect. So just taking the well-known surgical procedure to cover recession around teeth and transfer them to implant dentistry, this does not work. This is pretty well known today. When you look at the literature, the success rates of treating peri-implantal deficiencies in the aesthetic zone the same way like treating recession teeth, you will not have the same success rates. So there we need to create other ideas. And so we would, in this case, our favorite approach is always tunneling. And as we all know, that the blood supply in the papilla between an implant and a tooth is always not as good as when you have two teeth beside each other. So cutting a papilla between an implant in a tooth and a tooth is even more dangerous regarding the healing afterwards. And so in our opinion, in this situation, a kind of a tunneling approach where you don't cut to the papilla is, I would say, a more predictable outcome, a more predictable treatment or surgical approach to this situation. So we always try to do this in a tunneling approach, not cutting to the papilla, and combine this with a peninsular flap from the palatal side. So it becomes, and I have to admit that, a rather complicated surgical procedure. It's not an easy surgical procedure. As everybody knows, that tunneling procedures are for sure more difficult to perform than when you make a cut to the papilla and then prepare coronal positioning flaps, split full, split, and all this way. This is buccally, then much easier to perform. Going now in an approach where you have the same ideas, split, full split, but doing everything in a tunneling approach, this is clear for myself. This procedure is technically more demanding. But on the other hand, this is why we are in our hands, or why we think this is a better approach, is you have a better predictability. And predictability is, in our opinion, the most important thing for our patient at the end. That's why we prefer this approach.
Okay. So now I heard already for a couple of, maybe it's 2 years, that you're now calling it the peninsula flap. It has never been an island, huh?
Yeah, that's true. We went. You were clever. You were very good. We started to our book. We went very much in detail in the plastic reconstructive surgical literature, and you know that this peninsula flap was already published a long time ago in the plastic medical surgical approaches. And Carlo Tinti, 1995, was the first one using this technique in the molar area around implants for the uncovering of implants. And this was actually his idea. And we then transferred this today more to the anterior area.
Yeah.
Looking at the kind of cuts you use, it's a clear peninsula flap called today. That's a very good comment from you. We also can become better and better, and also the wording has to become better. That's true. You're right.
Yeah, it is a nicer wording if you have a peninsula flap instead of an island flap. It is a nicer wording. If you go back to this case, would you? So if you go for a tunneling procedure with or without a peninsula flap, depending a little bit on the size you have to augment or the volume that you have to augment, are you looking at the prosthetic restoration on beforehand, or is this something that you try to keep it in place, not during the surgery, but try to reuse the restoration, or are you looking at emergence profile on beforehand, maybe taking the crown off, see how we can improve the prosthetic restoration or the restoration itself?
Yeah, absolutely. This is a very good comment you made. We, in those kind of cases, first of all, I have to admit, when the defect is really big, then you need to take it off and cover the implant with soft tissue, and then start opening it again, reopening, and work then again. But when the defect is moderate, it's not a severe case, then we always take off the superstructure, because most of them, they are too bulky, they are convex. And this is one of the reasons why you got this deficiency there. And so then we create first always a screw-retained concave shape or concave emergence profile, long-term provision on the implant. And then we do the surgery to this new emergence profile. This is absolutely mandatory. Maybe you can, yeah, this is very difficult. Our way is clearly we create first a long-term provisional with the perfect emergence profile on this specific implant, which is concave, that we know very well from Van Doorn and Rompen. And then we install that, and then we do the surgery to the perfect emergence profile.
Yeah, I asked this question because if the listeners and the viewers, we are talking about just the surgery, but I think it's very important also to talk about the restoration itself, so that they don't go into just the surgery and see how they can do the surgery in a good way, but don't take care about the restoration, which is on top. So that was the reason why I asked you this question. There was a very good one that I also got. This was also a Belgian colleague that asked me, what did he say? Do you consider it standard of care performing soft tissue augmentation during immediate implant placement in the premaxilla? Because he sometimes sees or he has the feeling that in some cases this might be a little bit of over treatment.
In the premolar area or in the aesthetics?
In the premaxilla. So let us say from 3 to 3.
Yeah, I mean, this is a good comment. I mean, you really have to evaluate the case carefully and the expectation of your patient carefully. What do they really want? What is their expectation to the treatment? And, you know, sometimes you have a patient with a low lip line and you do the whole treatment just for a nice photograph. And I completely agree with him. So when you know, I mean, when you don't add a graft image, first of all, you know, what we have to do today, and this is very important, evaluating the case. You can have, you know, you can have your tooth, and unfortunately, this is most of the time like this, is extra alveolar. So the tooth is outside of the bone when you look at the CBCT. And such a case does always result much more than when you have a case where the tooth is inside the bone, the bony house. And this is the first thing which you should evaluate. As I said, because of so many orthodontic treatments today, which is done, we have many, many cases. The majority of the cases will have position of the tooth outside of the bone. And then those cases will end up with more resorption. So that's what you can evaluate already before. Then you have to really look at the expectation of the patient. If he doesn't care when you have a little bit of loss of volume, you place the implant where you know you have to place it, namely more palatal from the buccal bone. Then you get a little bit of resorption, you have a little bit concavity around this implant, but it doesn't, you know, it doesn't harm the implant. The implant is doing well there, and the patient has a low lip line. I agree. We are, you know, on the Congress, we always show the beautiful, most beautiful cases and working on high-end aesthetics. Then you have to do it. If you want to do that, the best what you can do today regarding the quality of the tissue, regarding the quantity of the tissue, looking at other priorities now than just the big aesthetic score, then it's clear you need to add an orthosis connective tissue graft. Or you have another option. This is our socket shield approach, which is exactly in this sense for the patient what he expects the most from you, because he doesn't like you to go to the palatal side and harvest the graft, or to the tuberosity doesn't have additional connective tissue graft. He would prefer that you only do a little bit on this remaining tooth and a little bit bone and place your implant and make the treatment, and having no pain and no morbidity, and up with a very beautiful result regarding volume, regarding quality. That's, in this sense, for sure, an option you should think about. You know, sometimes I think very old patients, you know, you have to extract the tooth. Maybe you have a little bit of healthy buccal side. Why not doing socket shield? Then the patient has absolutely no morbidity, zero. And this is what many, many patients, if you would ask them, really prefer. I'm convinced about that.
Yeah, definitely. And I've done quite some in private practice, and we've done quite some studies also in Leuven with the socket shield technique. And even if you, for example, would not tell the patient that you are going to do a socket shield technique, they don't even know during the surgery, because it's something that is just happening. It's not a procedure. It's just like you do what you need to do. And if you are a little bit experienced in it, and it doesn't take 2 hours also to do it. So that's definitely a good alternative. I was what was yeah, because you were telling about the patient where you have the tooth that is outside of the bony envelope, if you look at cross-sectional slices on cone beam CTs. And what you always hear on the congresses is that they always refer to these studies where they have extracted single teeth. So, and then they looked at the resorption rate vertically and horizontally, and they had go from, let us say, 40 approximately 50% to 11 to 22% in a vertical direction. But in the end, because they always show this on the big congresses, they always start with this: we're going to lose a lot of bone. But in the end, if you look at these numbers, actually they don't mean a lot for the patient that you have in your chair, because it's depending from the patient that is in your chair. He can be one that is gaining bone after extraction too, because these were mean numbers. So I think that is concluding very, very nicely that you have to check the patient which is in your chair and treat every patient like he should be treated, not as a mean patient.
Absolutely. No, this general approach, I completely agree. We have to be more careful in the evaluation of the case. And if the goal is to have a very well-functioning implant and the aesthetic is not the absolute important outcome, then I completely agree with you. If you place the implant right and you have the goal to have at the end this implant integrated in bone, 360 degrees around it, and you place it to the palatal side, you end in many, many cases with exactly this goal. But aesthetically, yeah, it doesn't look so wonderful, but some patients accept that. I agree completely. But what is dangerous, this is really dangerous at the moment. And we have this tendency, well, in Europe, even in the United States, when there is no buccal bone, how people are treating these kind of defects when they do immediate implant placement. This is a topic we should address in another interview once, because this is at the moment something where I think a lot of clinicians are informed in a way that there is no bone at the end. And then we are in another situation than the situation you just described. You said, okay, I placed the implant palatal and maybe I lose volume of bone, but at the end, my implant is integrated in bone, 360 degrees around it. This we know from the literature. We know this since 1961 from Emler and Schroeder, how much a extraction Sorten, inside the extraction, you get bone, up to 90%. This is well known already. And so you're absolutely right. But when there is no bone on the buccal side and you start to do here so fancy things, what many clinicians or many lecturers recommend, then you go in a direction where you create on the buccal side something which is radiopaque. That's true. In the radiograph, it is radiopaque, but you cannot say that this is bone. And this is something, I'm not against this concept completely, but when you do that, you should have 5 years data to prove that this interface you create there is stable, but you should have a controlled clinical trial and not just a case series to prove, yes, it works fine there. This is something which is completely missing, this kind of literature about this approach, and it's done worldwide. I know that.
Yeah.
This, I think, needs something we should discuss in another interview.
In another interview, yes. There was one also very good questions because and this is coming from a referral practice. I think this is a colleague that is doing a lot of cases where maybe implants had to be removed and then bone augmentation had to be performed, etc., etc. So these patients where you already have previous surgeries, so that means scar tissue, scarred periosteum, etc., etc. And what he is writing me is that, for example, in these cases, you have to do a lot of release of the flap, which is not easy due to the scar tissues, etc. Maybe you should use also the upper lip muscles in the upper lip, so the facial muscles in the upper lip to get the flap closed in one sort of way. And then afterwards you have to restore the vestibulum. Then you have to restore the volume, etc., etc. And now the question that he had was, and this is a procedure that is nowadays quite popular, I would say. what do you think about the long-term perspective of strip graft procedures where where a vestibuloplasty is performed and a sort of free gingival graft strip is placed deep into the vestibulum after such big augmentation cases?
So you mean using Vista, this technique from going from up, or?
No. I mean, if you have, I'm going to say it like it is. If you have destroyed the vestibular depth due to the fact that you had to close the flap, how you are going to restore this for the patient in the aesthetic zone. And for this, the strip graft technique has been proposed by putting the strip very high up in the vestibulum, do a vestibuloplasty, and then to working with substitutes, etc. What is your vision on this?
What do you mean? Yeah. No, we would not. This is a high risk, and the strip graft. I mean, first of all, it's nothing new. It was described, or we did it already 40 years ago. It was already done by my professor at that time. Temmerman did this already. But it's a pretty much a little bit something like Stafileno, who does exposure of the periosteum, but they didn't place anything on the periosteum. So we don't do that at all. We end up, when you do this technique, you end up specifically deep down in the vestibulum with a lot of scar tissue again, even more than before. And you cannot really control it very well. Then, what's happening in this area where you add your substitutes or for gingival grafting procedure, the color is also not really the color it was before. That's what they address. It might be, but as we discussed at the beginning of this interview, even when you do this expose of the periosteum, you don't get the color back which was there. This is shown already. And so in such a case, we would, as we already also discussed, always go with the peninsular flap and bringing what is there more to the buccal side, creating again mucogingival junction on the same level and on the neighboring teeth. This is what we would try in such a case. And when it's not possible, honestly, when it's not possible, then we would go, what I described already at the beginning also, with the graft outside. And when this is not possible, then we would go, because function stability is the most important thing. When there is mobile tissue around your implant in the aesthetic zone, it's for the patient really difficult to maintain. Then a normal free gingival graft is still a very good option. But going to a strip graft does not improve the aesthetic outcome.
Mm-hmm. Do you? Because I have never tried it myself. Where I've done some peninsular flaps, but can you let us say in these patients where you have really destroyed the whole vestibular depth due to the fact that you needed your flap to be closed? Can you, with a peninsular flap, maybe it is fully detached, can you fully recover the vestibular depth in this way, or is that an utopia?
Yeah, the case is what you just said. You can sometimes fully detach it, and it's not a peninsular flap anymore. But when it's only in the soft tissue, we do this also more and more. And when you ask me, this really depends on the case. When it's a really, really huge defect, no. I would say you are in a range of 5-6 millimeter can be possible, but more. So when it's more than 5 millimeter, 5-6 millimeter, you have to go back in the buccal side to recover the vestibular deepness. Then I would agree it's not possible, it's just a peninsular flap. And then, you have to look for other options. But honestly, the strip graft is not what we would prefer. I did this 40 years ago, but around teeth, not around implants. But we tried this already around implants. At that time, we were thinking, well, it's not me, because I was a young assistant professor in the Department of Periodontics. Werner Merman, Professor Merman said to me, let's try this. We don't have to harvest so big grafts anymore. We just can have a smaller one, and then we get the same good result. So we tried this already around teeth, but the color, which is the most important thing in this, what we discuss here, was not the same. So we don't see an option there. And scar tissue get also a lot, even more when you place this very up there. You place the strip graft very deep at the deepest point of the vestibule, then you get the scar tissue. And the scar tissue, you know, sometimes can specifically, and this is what I fight against when I do a free gingival graft around an implant. I fight exactly against that. What I'm saying, yeah. When you do the strip graft, you have a very high chance to get a lot of scar tissue exactly in the highest point of the vestibule. And when you get scar tissue in the highest point of the vestibule, and you don't get the smooth vestibule up there, you create for the patient sometimes a pain in the ass, you know. All the tissue, the food impaction up there in the vestibule, and the patient comes back then and complains about, you know, doctor, here up, I always have some food impaction down there. Can you do something? And this happens
even some sensitivity. Even like they feel that there has been a surgery the whole time.
Exactly.
Yeah.
So it's not our favorite treatment. No.
Okay. I think we have time for just two more. And this was a very interesting one. It's not about it can be in the aesthetical zone too, but this was a question that is more related to full arch cases. Might be in the aesthetical region too. How much vertical soft tissue augmentation can you, on average, expect in cases of implants without adjacent teeth? Because nowadays we see a lot of congresses that they are rebuilding the vertical height, the horizontal width, all with connective tissue grafts, like not one time, but 2 times, 3 times connective tissue grafts. But this has to have some limitation, right? It's not that, like you always say, we can't fool Mother Nature. But can we fool Mother Nature with connective tissue grafts?
I don't think so. But it's impressive, I agree. It's very impressive what you sometimes see on the meetings, how much they vertically can augment the areas. And it's for sure more, we can reconstruct vertically with soft tissue more than what the data said. You know, the data could say it's 3.5 millimeter between 2 implants. I would say today with the new technology, with the new grafting we are using, at that time we used subepithelium connective tissue grafts. We didn't use so many deepitalized free gingival grafts. And this is for sure a graft which has a much higher potential regarding the volume. This is the most important what I just said. Regarding the volume, the deepitalized free gingival graft has a not yet 100% understood and known potential. That's for sure. And there are already case reports where you can see how we have a case in our group 2, how this graft creates bone outside of the bone. And sometimes in the lower jaw, Otto placed the case here in the lower jaw, and then 5 years later, you had bone outside of the bone created by the graft. You know, this sounds everything great, and we see great cases, as you just say. I would agree more than 3.5 millimeter in the literature say, but you know, the most important thing is always, what about the predictability? And this is what I said at the beginning today of our interview. You know, how predictable does this work? Can we predictably say, if we take now a deepitalized free gingival graft and we deepitalize it 0.4 millimeter, we still have epithelium cells in there. Maybe we use a diamond burr, then we may be a little bit better. Maybe they react a bit different, but I always say maybe. We don't know. We have a lot of hypotheses. We have a lot of assumption in our mind. And we see cases, as you said, which are incredible. But I would guess that nobody of these people who are doing these kind of things will tell you this works in my clinic 95%, I would guess. Because this is our main guideline in our clinic is when we do something, recommend something to the patient, in our clinic, it needs to work up to 95%. And I would really bet that nobody is able to say to his patient, I'm going to augment now soft tissue, 7-8 millimeter in your case. This is going to work on a 95 predictability. I would guess nobody can say that. So, this is the dangers, what's happening at the moment. I call them the digital influence or the professional influence we have in dentistry. What is happening there? They show us beautiful cases, no doubt. But yeah, I remember my time when I was young, I did crazy things. For instance, as a good example, I used rubber dam as a membrane to do guided tissue regeneration around teeth in 1987. And, I did about 15 cases on the Department of Periodontics. And 2-3 cases were great. And the other cases were a disaster. So, when it's something you try, you have some great result, but first you have to prove, and you have to do controlled clinical studies to prove that this works up to 90-95%. And this is not done. There is nothing available about that. No data. Beautiful cases. We have at the moment all the time case presentation on those meetings, and it looks amazing. In my opinion, sometimes, when you look at those cases and they grow, then afterwards it looks like a tumor around the implants later on. So it doesn't look natural, actually. Sometimes you have the feeling they create something. Yeah, it's a lot of tissue there, but it doesn't look natural anymore. This is also not good. But most important thing, I think, let us really, as a community, work more to find out all these mechanisms. Why do they grow? What is important to look? Is this anterior, posterior, like a new study now I just saw this weekend. Tony Sculian did a study where he evaluated histochemically, immunohistochemically the tissue, and could show huge difference between anterior and posterior regarding how do you say, there were more BMPs like material in the posterior than the anterior area. And there now we could already start to think different. Maybe posteriorly, when you harvest there, you have a higher chance to get those, or that those grafts create more bone because they have more BMPs in the anterior, they have less. These are hypotheses, but this is what we mean, Otto, myself. We need to understand it better. We don't know it. And giving these recommendations by showing some cases is incredibly dangerous. And as I said, when you ask me, I would say we are better, maybe 5-6 million, but on a predictable base. Question. And then comes another issue in this field, and this is what type phenotype do you have? And this is something we already know. When the patient has a thick biotype, then you have a higher chance that the tissue is growing afterwards, that you get more tissue, that you can create tissue, and you have it more stable afterwards than when you have a thin biotype. Even when no teeth are there, the patient has from his attitude, he has a kind of phenotype, and this is also hypothesis, I don't know. I would assume that these patients are more delicate to augment than the case who had a thick biotype around around teeth. So, as I said, now this is at the moment a field where we don't know exactly. And I would assume that if you would do 30 cases like they show you in the YouTube and this in the meetings, out of the 30 cases, maybe 10 come out like they show, and the rest I would like not to see. This is my opinion. And
Good. Yes, indeed.
Opinion, you know.
Yeah,
From
indeed.
all
Yeah, this is something that we don't know a lot about. We know, maybe you know our study in Leuven where we have looked at the alveolar phenotype, where we have transposed augmentation site over the contralateral site, which was intact, and then we saw that augmentations always go back to the original, what Mother Nature gave us in the first place, even a little bit less, not more, but even a little bit less than the natural contralateral site. So there must be something also that exists, which is the soft tissue phenotype that we cannot augment like 10 kilometers outside of space, and that the body will always restrict us to certain boundaries.
You see, this is exactly what I said. So you
Yep.
find those, you go in the same direction. This is also our feeling. But as I said, it's our feeling. And we have to really place it this way that we don't, you know, we cannot become professional influencer by showing nice cases. At the end, we also have really to address to evidence and we need to make evidence. We cannot now start with nice cases and this, you can do it this way and a short 2 millimeter video, do it this way, and then you achieve the same like I. This is what's happening at the moment, and this is very dangerous. I'm really a little bit afraid about the development in this field when I look a little bit up in YouTube, what is shown there. And it's, you know, young dentists get some information how to do it, a 2-minute video, and then a nice case, and then they go and do it. And
yeah, indeed.
There is no serious study behind it. And then
no, indeed. And maybe this is next to all the things that we already have discussed, also is a very good take-home message that that they have to look at it with their full head in mind, that they are thinking about how can this be possible, and is this not just the case where everything worked out, but maybe there are 10 cases thrown into the garbage before this one case comes onto the stage. So that's definitely one to take home. So Markus, before we said that we would take it as 50 minutes to 1 hour. I think we have done it. We sticked nicely into time. There are some other questions, but if I would throw this into the discussion, then we are lost. But we still, there may be some opportunities in the future to redo this, also definitely with other topics. So I thank you very much, and also thank you from my behalf that I could be the first one to go into this new project with the Hürzeler and Zurich Academy. I think it will be very nice for the listeners and the viewers to hear your insight already on quite, let us say, into detail topics that we have discussed. And yeah, that's it. If you have something to add, then please do so.
I would like to thank you, Andy, to really follow and go out of your comfort zone and try new things with us. This is really, I really appreciate Otto and myself. I really appreciate that you sacrifice your time and prepare this interview. You make that, not I. I got those questions. I didn't see the question. I got them just like this. I like that. I want to be spontaneous and give the answers spontaneous. And for me, it was a wonderful time. I felt really good, very nice here. And I hope really that the people will look at it, and maybe out of that, it develops even more questions, and then we can address them in the future.
Yeah.
Thanks a lot. Thanks a lot, Andy.
Perfect.
Great. Thank you.
I would say enjoy your evening, and don't dream about soft tissue graft this evening.
Thank you. Bye-bye.
Thanks.